Hello, welcome to Pre-Op Education. My name is Bonnie. I am the physician assistant for the Bariatric program here at Valley Health. What we're going to talk about today are possible complications, what takes place between now and the time of surgery, what to expect during your hospital stay, and what to expect in those first couple of days home. First thing we want to discuss is the difference between open and laparoscopic surgery, because when you read your consent forms, you are going to sign a consent giving permission for a laparoscopic gastric bypass or a laparoscopic duodenal switch or a laparoscopic sleeve gastrectomy with permission to open if indicated. So what does that mean? When bariatric surgery first began, it actually began as early as the 1950s, and in those days the only way we could do surgery was to cut you from stem to stern. So you had an incision that went from your breastbone to your belly button. Depending on how tall you are, that is between a 5 and 7 inch incision. They then divided down the muscles and did your bypass. When you make a big, long incision, people tend to complain of more pain. There's a higher risk for wound infection and a higher risk for hernia after surgery. Plus, the bigger the wound, the more scar tissue it creates. So in the early 1990s, laparoscopic surgery came about. And we went from making one big long incision to basically 6 stab wounds, 5 of which are about the width of my thumb, 1 of which is about the width of my pinky. The width of my pinky is the one that goes up under the breastbone and is used for holding a liver retractor. Your liver is sitting right on top of where we need to get to operate, and we need to be able to get up underneath it. That's actually the reason for that 16-day diet prior to surgery, is to help shrink the size of the liver, making it safer and easier to access. So, why would we ever open someone up? There are basically 3 major reasons. 1, difficulty seeing inside the abdomen. The most common cause of that is actually previous scar tissue. So if you've had an open gallbladder surgery before, for example, you're likely to have more scar tissue in that general area versus having had it done laparoscopically, where you typically create less scar tissue. Excessive bleeding, obviously. If we need to get in there to stop bleeding, we will do so. And if we were to incidentally perforate your stomach or another major organ. Where we are operating, your esophagus, which is the tube used for swallowing food, comes down and hits your stomach. Over to the right is your gallbladder and your liver. Over to the left is your spleen, and behind all those structures is your pancreas. So there's quite a few things in the area in which we are going to operate. If inadvertently a hole were put in one of them during surgery and they needed to get in to fix it adequately, they will do so. So one of the big, bad, and ugly things I have to tell you about is that 1 in 300 people die every year from bariatric surgery in this country. It is a statistical fact. There is a death rate from having your gallbladder out, from having a C-section, or from having your tonsils out. Blood clots are another complication. This is one of those times where an ounce of prevention is worth a pound of cure, so we're going to do quite a few things to help prevent blood clots along the way. When blood clots occur, the most common place for them to occur is in your leg, and we call that a DVT. It may occur anywhere along the leg, but the most common spot is in the calf. When that does occur, people tend to complain of pain, redness, swelling, all signs that you have a wound infection, but you have no wound. The problem is when blood returns from our legs, the next place it's going to go that has small blood vessels is our lungs. And if a piece of that clot were to break off, it could get lodged within the lung, and that is called a pulmonary embolism. When that occurs, people complain of chest pain, shortness of breath, or really difficulty taking a deep breath. They describe it as if you're trying to take a deep breath with an elephant standing on your chest. And their heart rate may go up as well. So what are we going to do to help prevent those? Well, anytime you are in bed, you're going to have ankle pumps on your feet. If you get up and go for a walk, the nurses will take the ankle pumps off, but as soon as you get back in bed, you're going to have those ankle pumps put back on. That's going to help mimic the action that muscle would take and return blood from our toes up towards our heart. These exercises, by the way, are in the back of your handbook. Please review the back of your handbook with these exercises in it. It's in the hospital stay section. The ankle alphabet, all it is writing the letters of your alphabet with your feet. A, B, C, while moving your ankles. Quadriceps and gluteal sets, that's just squeezing your butt and thigh muscles. Heel raises. When you do heel raises, you lay with your feet up. You will pull your toes up towards your nose and hold them for 5 seconds. Point them down towards the floor and hold them for 5 seconds. Pull them up towards your nose for 5 seconds and point them down towards the floor for 5 seconds. And last but not least, everyone will be on Lovenox while they're in the hospital. Lovenox is a blood thinner. It's given by injection under the skin, usually in the lower abdomen or lower belly. Some of you get the pleasure of going home on Lovenox, those who are particularly high risk for getting blood clots. So who gets to go home on Lovenox? Well, if you have 2 of the 4 criteria on the left, so your BMI is over 50, you have sleep apnea, obesity hypoventilation syndrome, venous stasis disease is where you get a lot of swelling in your feet, or you are male. Also, those who have had a history of some types of cancer, previous cancer treatments, you're over the age of 60, you've had a history of a previous blood clot, or have a vena cava filter, you would also get to go home on Lovenox. Most often, our courses of Lovenox are done for 2 weeks. Occasionally, somebody who is very high risk might get to go home on it for 4. A leak. A leak is where the staple or suture line does not seal off completely, so that things that should be staying within your gut are leaking out into the area around it. It is life-threatening and generally requires a trip back to the operating room for them to wash out any infection and possibly put in a drain if necessary. If that were to occur, people tend to complain of abdominal pain, a rapid heart rate. Key number is a heart rate over 120 at rest. Fever, obviously if you're brewing infection, we tend to run fevers. Decreased urination. 1, your kidneys get kind of insulted by this, and 2, as we run fevers, we need to drink more fluid to keep up, or we tend to get dehydrated. Belching of foul odor. If you think about it, if you're brewing a pus pocket right about here and you burp past that, you can imagine what that would taste like. Left shoulder pain. You can get either shoulder pain. Left is definitely more common. We are operating underneath your diaphragm. Your diaphragm is the muscle that helps you breathe. The nerve that goes to the diaphragm comes from the shoulder, goes down the chest wall, and ends up at your diaphragm. So when you irritate the diaphragm, you will tend to feel it in your shoulder. And last but not least is anxiety. And this is not I'm worried or I'm anxious kind of anxiety. This is this sense of impending doom. I know I'm going to die, I just know it kind of sense. The most common days to see a leak are post-op day 3 and post-op day 7. Actually, we will test for a leak before we leave the operating room and make sure we don't see one at that time. A fistula. A fistula, by definition, is just an abnormal connection, a connection we do not want to occur. It can happen between the stomach pouch to your old stomach, stomach to intestine, stomach to skin, or intestine to intestine. The treatment for a fistula depends on location and it depends on size. Keep in mind it's caused by abnormal scar tissue formation. The more we get in and operate, the more scar tissue we create. So sometimes the best plan is to leave it alone and allow it to just seal itself off. However, it can be kind of frustrating to be told, hey, we know there's something wrong, but no, we're not going to go in and operate and fix it. If, however, it is creating some problems, there are times when it is necessary to go in and reoperate. Ulcers. You're at risk for ulcers after surgery. The risk for ulcers after surgery goes up. If you continue to use tobacco products after surgery, the statistics are astronomical for getting ulcers. So that is why we harp so strongly on quitting tobacco before surgery. The treatment for an ulcer after surgery is the same as the treatment for an ulcer before surgery. So initially we use an antacid medicine, something to suppress the acid level in your stomach, and something to coat the stomach over, the ulcer over, and kind of soothe it. And we give it some time. And it may take 8 weeks or more to heal an ulcer. If, however, it does not heal, or it were to eat all the way through the stomach wall, it would require a trip back to the operating room to fix it. Stricture. A stricture is an area of basically too much scar tissue formation, where the scar tissue basically makes an area that becomes a little too tight. Generally speaking, you don't see those for 4 to 6 weeks out from surgery because we have to wait for scar tissue to completely form. People tend to complain of difficulty swallowing, they may regurgitate or vomit, they feel like things get stuck. Often I get told that my shakes go down fine, soup goes down fine, but as soon as I eat something solid, it just feels like it sits right there. The treatment for a stricture is to do an EGD, and that's where they take the telescope lens and they stick it down into your stomach. And they stick a balloon in there and just sort of stretch it out. It does not require a hospital stay. You generally go home the same day, but you do have to have somebody drive you home. With both the sleeve gastrectomy and the duodenal switch, there is a slightly higher risk for reflux after surgery. It is higher with a sleeve gastrectomy than it is with a duodenal switch, but that's because when we cut off the portion of the stomach that we remove, we make a long straight tube of a stomach, which just makes a nice shot for acid to go right back up the esophagus. With the duodenal switch, you're also at a higher risk for nutritional deficiencies. It is absolutely essential that you be dedicated to taking your vitamins every single day if you are considering having a duodenal switch. These nutritional deficiencies are preventable. You are at higher risk for osteoporosis, anemia, and just overall poor health because of it. You also need to be dedicated to getting annual blood work done so that we can assess any of those nutritional deficiencies and treat them right away. So the goal of bariatric surgery is to make you healthier, right? We spent a lot of time convincing your insurance company that we were doing this to make you healthier and not for cosmetic reasons. However, now that we have done that, we get to smile and say, but there is no guarantee. There are some medical problems that really are just genetic, and it doesn't matter how much weight you lose, they may or may not improve. We have pretty good predictions for which health problems will get better with surgery. But again, sometimes we don't get off all of our medication from them. So between now and the time of surgery, if there's any change in your overall health, we want to know about it. Doesn't mean we're necessarily going to change what we're going to do, but we want to be prepared when we go to the operating room. We want you to stop taking any non-steroidal anti-inflammatory drugs. Those may be both over-the-counter or as prescription. Some of them are Advil, Aleve, naproxen, aspirin, Celebrex, or diclofenac. If you are looking for a pain medication to take, Tylenol is okay. Those medications increase your risk for bleeding. If you are taking aspirin because your cardiologist says you need to be on an aspirin because of your heart, you should have a plan with your cardiologist as to when you should stop that prior to surgery. We also want you to stop taking any herbal and natural medications or remedies prior to surgery, except the vitamins that we have you on. A lot of those medications are not FDA tested, and therefore we don't necessarily know all of the side effects or drug-drug interactions. And also if you are taking any hormone replacement therapy, that would include estrogen, progesterone, testosterone, birth control pills, or Nuva rings. We want you to stop those 2 weeks prior to surgery. You may resume them 1 month after surgery. Those medications increase your risk for getting blood clots. However, please be aware, if you stop your birth control, you can get pregnant. We do recommend using an alternative form of birth control after surgery. I want you to take out all of your pill bottles and look for the letters SR, ER, XR, or CR on them. That often includes your antidepressants, so Paxil CR, Wellbutrin XL. Those medications are extended release. All of those letters, SR and ER stands for sustained release, extended release, controlled release. Those medications are designed not to break down in your stomach, but to wait until they're in your intestines to break down. The problem is when we skip a large section of your intestines, the odds are you won't absorb them completely or adequately. We recommend you call the physician who prescribes them and have them switch to a regular release version. All of them have an equivalent in a regular release version. It may mean taking it more than once a day. Also, I want you to look at your pill bottles for the letters HCT or HCTZ. That stands for hydrochlorothiazide, and that is a fluid pill. If it is in its own separate bottle, you don't need to do anything with it. If, however, it is written as a combination with another drug, such as lisinopril HCT or Prinavil HCT, we want you to call the doctor who prescribes it and ask them to split it into 2 separate prescriptions. HCTZ, or hydrochlorothiazide, is a fluid pill. After surgery, you're at higher risk for dehydration. We'd like to be able to stop your fluid pill, but not necessarily stop your blood pressure medicine. So that's why we need it as 2 separate medications. Now, you may take the extended release and the combined blood pressure medicine and fluid pill up until the day before surgery. It's not going to make a big difference until after we start rerouting things. It seems silly I have to tell people this, but we should be taking good care of our teeth. Most of us got 2 sets and we went through the first set already, so you got what you got left. Brushing and flossing your teeth regularly is an important part of preventing post-op infections. When we do surgery, we are going to take a tube and we're going to stick it through your mouth and right down into your lungs. And we'll also take one and stick it right down into your stomach. If you have nasty, gross, disgusting teeth, we're going to pick up all those bacteria and stick them right down into your lungs. If you want to talk about a great way to get pneumonia after surgery, that's it. So there is some data to support the use of Listerine prior to surgery that swishing and spitting once a day with 30 mLs, just like it says on the bottle, will actually reduce your risk of postoperative infections. And I put on there at least 2 weeks prior to surgery, but honestly, why wait? Go ahead and start. Oral hygiene is very important to overall health. You should have an appointment over at the START clinic, which stands for Scheduling, Testing, Assessment, Registration Team. When you go over there, they are going to do some additional blood work. They will do an ECG, which is where they stick those 6 sticky things on your chest and look at your heart rate. You will get a urine test. If you're a female of reproductive age, they're going to make sure you're not pregnant. They're going to do a chest x-ray, and they're going to check your height and weight. Also, if you use a CPAP machine, you have 2 options. You can bring your entire machine and contraption with you to the hospital, or you can utilize a hospital system. If you are choosing to utilize a hospital system, respiratory therapy would like to get your settings when you're over there at the START clinic. That way they can go ahead and get your machine ready before you even make it through surgery. You generally have one more visit left before surgery, and that is going to be your consent appointment. You should have been sent a link to watch an online video and take a true-false test. If anyone does not feel comfortable taking the test online, or they feel they would benefit from having someone read them the test, we can accommodate that here in the office on the day of your consent appointment. Just let us know in advance. When you come in for that consent appointment, you will get a basic physical exam. Doctors are just going to make sure you're still healthy and safe for surgery. And last but not least, they're going to go ahead and give you all of your post-operative prescriptions at that time. So all the prescriptions you will need when you go home from the hospital, we're going to give you beforehand. So you can go ahead and get them filled, and you don't have to stop by the pharmacy on your way home from the hospital. So what will you get prescriptions for? You will get prescriptions for Zofran, which is an anti-nausea medicine to be taken as needed for nausea. Pepcid is an antacid. We put everyone on Pepcid for 3 months after surgery. Potassium, everyone is on potassium for 30 days out from surgery. It's a big complaint. People don't like to take their potassium. However, it is very important that you get it. And you will be much better off to take your potassium every day than to get stuck getting IV potassium, which is 1, uncomfortable, and 2, takes a long period of time. So please make sure you get it. The bottle may say on it, do not cut or crush. Please ignore it. It won't go down whole. You may crush it and put it in some applesauce or yogurt, or you may cut it into quarters and take it 1 piece at a time, whatever it takes to get it down. And last but not least, you will also get most family pharmacies do not stock Lovenox because of its cost prohibitive. So generally we use Valley Pharmacy, which is the hospital pharmacy for filling the Lovenox. They will actually contact you before surgery and let you know if you have a copay, and they will deliver it to your hospital room while you are there, so you don't even have to stop by and pick it up. So the day before surgery, you're on clear liquids, and when you get to the nutrition section of pre-op education, they'll review that in more detail. It's nothing to eat or drink after midnight. Men, we do ask that you shave all of your facial hair. It helps get a good seal on the mask during surgery when they're intubating you. When you go over to the START clinic, they're going to give you a bottle of something called HibaCleanse. HibaCleanse is an antibacterial soap, and we want you to shower with that the night before and the day of surgery. You basically need to scrub your torso region. Reach around your sides as far as you can get as well. That's going to lower the bacterial load on your skin and reduce your risk for getting wound infections. People do tend to complain that it dries their skin out or leaves a film on their skin. And we do ask that you don't put any lotions on the day of surgery. But given the choice between a wound infection or dry skin, I'd have to say I'll take the dry skin for 24 hours. Also, we want you to take your first dose of that antacid the night before surgery. That's going to lower the acid load in your stomach at the time of the operation. When you pack for the hospital, we want you to bring things like robes and slippers. We're going to have you walk in the halls, so you want to make sure you've got something that you feel comfortable doing that in. You can bring your pajama pants and things like that as well, so that you feel comfortable. Also, you may pack shampoo and deodorant. We will let you shower the second day after surgery. Lip balm, when we intubate you for surgery, we blow a lot of air at your face, and it does tend to dry your mouth out a little bit, so some chapstick can be helpful. Loose-fitting clothes for discharge. We just stabbed you 6 times. You probably don't want to put on anything real tight and restricting. And also your CPAP machine, if you're choosing the option to bring your own, please bring your machine, your mask, and your tubing, the entire thing. Don't bring anything valuable, though. We're not going to take responsibility for that. The day of surgery, you're going to go to AM admissions, and for that you will park in the green lot, B lot, around the main entrance of the hospital and go in through the main entrance, and AM admissions is down to your right. However, there is a volunteer desk there, so if you're not sure where to go, please stop. They will be more than happy to help you. You will meet with nursing staff, and you will meet with anesthesia when you are there, and they're going to have some more consent forms for you to sign. They will change you into a gown. They're going to put those foot pumps on that we talked about, and you will get your first Lovenox injection before you even go back to the operating room. Your family may wait in the waiting room for you during surgery, or if they were kind enough to skip breakfast because they knew you couldn't have anything to eat or drink and they would like to go down to the cafeteria and get something, they can actually check out a pager and they will get updated when you get into the operating room, when you come out of the operating room, when you get your room assignment number, and when you get transferred up there. If, however, they're going to leave the hospital completely, please make sure we have an emergency contact number available. For surgery, you will have general anesthesia, which means we are going to intubate you for surgery. We will be monitoring all your body systems, your blood pressure and your pulse and your temperature and your blood sugar and your carbon dioxide, your oxygen, you name it, we're going to be checking it. And we were going to have those foot pumps on the entire time you're in the operating room. After surgery, you're going to go to the PACU, or the post-anesthesia care unit. Most people stay there between 1 and 2 hours. How long you stay depends on you. When you wake up, you're going to have oxygen running to your nose. You may be nauseous and you may have some pain. We're going to get your nausea and pain under control before we transfer you up to the floor. So that's why it varies person to person. It is not uncommon to need some insulin after surgery. It does not mean we made you a diabetic, I promise. Those who are diabetic or pre-diabetic are at the highest risk for needing insulin after surgery. The problem is that your body's natural response to stress is to raise your blood sugar. And that doesn't matter if you're being chased by a lion, fighting with your spouse, or having surgery. All of them are going to raise your blood sugar. The second thing that's going to happen is that we're going to give you a dose of something called Decadron while you're in the operating room. Decadron is a steroid, which also raises your blood sugar. However, it's great for controlling post-anesthesia nausea. So given the choice between slightly high blood sugars and nausea, I think I'd take the high blood sugars. Often we can give you 1 dose of insulin, and that does tend to bring those sugars down, and we will then continue to monitor it. Most of our patients go to the 4th floor, which is where the bariatric unit is. All the patient rooms are private. The hospital is wireless, so feel free to bring your electronic devices. You can update your Facebook and your Twitter and whatever else it is that you do. Also, you have access to the Get Well Network. So the Get Well Network is done through the hospital TV system and includes educational videos. And which videos you get assigned depends on you. So if you have a bypass, you will get assigned a bypass teaching video. If you're going home on Lovenox, there's a Lovenox teaching video. However, here's the trick. You must complete your educational videos before you can have access to regular television. So this is kind of like, until you've done your homework, you can't watch TV. So please let your family members know, if they'll be waiting with you, that they should bring something to keep them entertained while they're in the hospital until you've gotten an opportunity to watch those educational videos. They won't be able to turn on the television as well. Day of surgery, we're going to focus a lot on pain management because, quite frankly, if you hurt, you aren't going to do much else that we ask you to. So we're going to do a lot to keep your pain under control. We're going to do a lot of coughing and deep breathing exercises. One of the most frequent complications after any abdominal surgery is something called atelectasis. Atelectasis is where the air sacs at the very bottom of the lungs start to collapse. And they do that because it hurts to take a deep breath, so we tend to breathe more shallow. So we're going to do a couple of things. One, everyone is going to get a berry bear or a tummy teddy. Tummy teddy is used for splinting your belly when you cough so that it will help reinforce the wounds from the outside, making it more comfortable. You are also going to be given an incentive spirometer. It's a plastic breathing machine that forces you to take big, deep breaths in. We want you to be using that about 10 times an hour while you're awake, which is about once every 6 minutes. You can do that 10 times an hour on the hour every hour, or you can use it, say, during every commercial break, and which would factor to about once every 6 minutes. The nurses on the floor will demonstrate how to use it correctly so that you can get the most out of it. Also, for the first 24 hours, we usually have you on telemetry, which is a heart monitor. So when you wake up, you're going to have a heart monitor on, and we usually take that off the next day. The day of surgery, you're mostly going to get just some ice chips and some sips of clear liquids, not much else. Good news is you won't really be hungry for much else. We are also going to have those foot pumps on and working. Anytime you get back in bed, those foot pumps go back on. We'll be checking your vital signs fairly frequently, and also we will have the head of your bed elevated to about 30 degrees. The reason that we do that is that we tend to take more shallow breaths when we lie flat. So by elevating the head of your bed just slightly, it does help you breathe a little more deeply. You may have a sore throat from the breathing tube, and that is pretty normal. You may also have some dry mouth. You can also have shoulder pain or discomfort. When we operate, we blow your belly up with air. That's what creates the space in there for us to operate. When we're done, we deflate your belly and we get the air out. However, unless we hooked up a vacuum, we couldn't possibly suck all that air down. When those air bubbles settle up under the diaphragm, they irritate it. And as we talked earlier, when you irritate the diaphragm, you tend to feel it in your shoulder. You may feel free to let your nurse know about that pain in your shoulder. However, please don't be surprised if she smiles at you and says, "Great, let's go for a walk." More effective than pain medication is movement for helping to resolve that pain. Basically, as long as those air bubbles sit in the exact same location, they tend to grind on that nerve and irritate it. So getting up and moving tends to be more effective than pain medication. So the day of surgery, we're going to get you up and walking at least 4 to 5 times. This is going to help prevent respiratory complications and blood clots. But please, 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 the first time you get out of bed, do not attempt to do so on your own. Oftentimes we feel that anesthesia has worn off better than it has. And we really want you to be assisted getting out of bed the first few times. Your nurse will let you know when she feels like you're safe to get out of bed alone. Postoperative day 1, this is the day after surgery. You may be tired and uncomfortable. We are going to continue with all those breathing and coughing exercises. We will continue with all the anti-blood clot exercises. We are going to get you up and walking at least 4 to 5 times that day. You will get visited by physical therapy, and we generally come in and round as a group the day after surgery. So, the day after surgery, your surgeon, if not both surgeons, our nurse practitioner or I, one of our dietitians, our psychologist, as well as our program coordinator, the unit manager, and the educational coordinator, and even your nurse, if he or she is available, will all come into your room at one time. The great thing about that is, one, we're all on the same page. Everybody knows kind of where we stand. And if there's anything you feel we could do to improve upon our program, we want you to speak up because the odds are the right person is in the room to deal with it. After that, individually, one of us will come in and check your wounds, make sure all that looks good, things we're not going to do with 10 people in a room. And the dietitian is going to come through individually and review your dietary stages so you know exactly where you're going and what you need to be doing. Postoperative day 2, most patients get to go home. Usually around noon, we tend to send you home. We will go through all of your medications before you go, and that's the day you get to shower. And that'll be a wonderful shower because when you've gone 24 hours without one and had surgery, there is no better shower out there. Day 3, now you're at home. Guess what? You can continue all those coughing and deep breathing exercises at home. Your Berry Bear or Tummy Teddy and your incentive spirometer get to go home with you because they're single patient use only. So you can continue doing all those deep breathing. We also want you up and walking from the time you get home. Postoperative day 1, you might make it as far as your mailbox and back. If you live on a country road, you might not make it that far. But we want you to be getting up and getting your water on your own, things like that. We don't want you sitting around all day having people bring you stuff. I know it is tempting when you get home to jump on the scale and go, did it work? Did it work? However, I encourage you not to do so. When we operate, we do give you a fair amount of IV fluids, and we do that on purpose to help prevent you from getting dehydrated as soon as you get home. However, it can be very discouraging to get on the scale and realize you've gained a little bit of weight from those IV fluids. When you've gotten to this point and you've been through what you have struggling with weight in the past, that's not a good way to start off. So what I encourage you to do is just wait until you are a week out from surgery. We will weigh you at that appointment, and then we will release you to enjoy your scale at home. If you are taking medication for blood pressure and blood sugar, we want you to be monitoring those very closely. Often we change those medications when you're in the hospital, and we encourage you to have a follow-up with your physician within 1 or 2 weeks after surgery. If you're relatively healthy, you only take maybe an antidepressant and you don't need to see your physician for 6 to 8 weeks, that's okay. But those that are really watching their blood sugar and blood pressure should be seen relatively soon. We also do not recommend the use of any of those NSAIDs, those non-steroidal anti-inflammatory drugs. Those medications increase your risk for getting ulcers, and that's a lifetime recommendation. If you are taking an aspirin a day because your cardiologist says you need to be on it for your heart stents, please continue taking your aspirin a day. It will still increase your risk for getting ulcers, and we need to be aware of any abdominal pain or belly pain that you get along the way. But it doesn't really matter what your stomach's doing if your heart ain't working right. Showering. Showering is good. We want you to do that. Once a day, let water run over the wounds and pat them dry. You don't need to scrub them. or put any ointment or use peroxide on them or anything like that. Just leave them alone. They generally heal well on their own. You may drive 1 week out from surgery, but it is 1 week and not taking pain medication. Taking pain medication while driving is considered driving under the influence. Also, we don't recommend any long-distance travel. If there were a complication, we'd want you to be able to get back to Winchester Medical Center for treatment. If you want to go for a few hours down to DC, for example, and go check out some museum, that's okay. But we do recommend that if you're in the car for more than 2 hours, you do get out and walk periodically to help prevent your risk of getting blood clots. Some concerns. So, nausea and vomiting. We do recommend you fill your anti-nausea medicine before surgery. However, if you're vomiting more than 3 times a day, we do want to know about it. We don't want anyone getting dehydrated at home. Also, you may get some insomnia after surgery. It's not uncommon. Keep in mind that if you're napping periodically throughout the day, it can be a lot harder to go to bed at night. Also, fatigue. Right after surgery, your caloric need to maintain your current body weight is still up high. However, your caloric intake, the number of calories you're getting in, is still pretty low. And the difference between the two often means that you may feel tired. As you lose weight, you need fewer calories to maintain your current weight. And as we increase your diet, you're going to get more calories in. And as those two become a little closer together, the fatigue should improve. So if you are having any trouble, what do? If it is during office hours, please call the clinic first. If it is after hours, you can call the hospital at 536-8000 and just tell them you need the bariatric surgeon on-call paged, and they will page either Dr. Glimbot or Dr. Wedor. If you are in doubt, please go to the emergency room. Things we definitely need to know about. If you have a fever over 100.5, we want to know about it. If your temperature is less than 100.5, the most common cause of a low-grade temperature after an abdominal surgery is atelectasis, the collapsing of the lower lungs. So try using your incentive spirometer 10 times and then recheck your temperature and see if there's any improvement. Increasing pain. So every day your pain should be getting a little bit easier and easier and easier. If all of a sudden it starts getting progressively worse, we want to know about it. Now, if your pain is getting better and better and better, and then you start feeling well and you think, I'm going to go back to work today, or I'm going to go out and go shopping, and that day you feel really tired and worn out, like you might have messed everything up on the inside, that's okay. That's pretty normal. That's just from being up doing more. But again, each day should start getting easier at that point. Also, if you can't drink fluids, we need to know about. We don't want anyone getting dehydrated at home. You generally have an appointment in the clinic 1 week out from surgery. At that appointment, we're going to check your weight, we're going to check your incisions, and answer any questions you have. 2 weeks out from surgery, you will have postoperative education. Things we want you to remember. Surgery is not a cure. Obesity needs to be seen as a lifelong illness, and we want to see you once a year to follow you up, see how you're doing, check your labs, those kinds of things. In the future, it may be necessary to remove your gallbladder. If you've already had your gallbladder removed, you're in luck, something you don't have to worry about. However, rapid weight loss increases the risk for forming gallstones. One of those random medical facts. So if your gallbladder starts causing problems in the future, we'll deal with it when it comes. Support. Support is essential for long-term success. And there are 2 options for support groups. One, our program offers a support group on the second Wednesday of each month over at the conference center at the hospital, and that is led primarily by our dietitians. However, they also have lots of guest speakers that come and talk. There are also online support groups available. My recommendation on those is take what is beneficial and leave what isn't. A lot of the online support groups are not led by medical professionals, so they often have great information on recipes and how to not waste food and how to meal plan. But if they're trying to give you specific medical advice, please check with us. And I just want to say congratulations, you're on your way, one step closer to getting through this process.